Hi, I'm Dr. Kimberly Thomson from IVFMD, and I'm here today to talk with you about ovarian reserve, and in particular about diminished ovarian reserve. So first of all, a little bit of background. You may or may not have heard, but we as women are born with a certain supply of eggs, and we use them up as time goes by. So we start with a certain number, and eventually we run out of eggs, and that's when our menopause happens and our period stops. Some women are born with a higher supply of eggs, so they have menopause later. Some have a lower supply of eggs and have menopause sooner. The average age to have menopause is approximately age 51. The eggs also, as they age, don't only decline in numbers of eggs, but also the numbers that are the good quality ones. As we age, our eggs are getting older with us. More of them have things that go wrong with them genetically that make them not the good ones. A fertilized egg that's not a good one may dissolve before the embryo even attaches to the lining of the uterus, so it just shows up as a non-pregnant month. Or if it has a chromosome abnormality that isn't critical so early, then the embryo may attach and the woman might get pregnant, but she might miscarry later on. Now, to assess how a woman's egg supply is doing, there are several different tests that we can do. One that's very important is a hormone called anti-Mullerian hormone, or AMH. Basically, all the little follicles, which are the pockets of liquid in the ovaries with the eggs, make some AMH. So the higher the egg supply is, generally the higher the supply of eggs, and the lower the AMH is, the lower the supply of eggs. So this way we can tell better how a woman's egg supply is doing. It seems to be stable throughout the cycle, so it doesn't really matter if it's drawn on the period or later in the month. Unlike the second test that we usually do to check on egg supply, which is measuring FSH hormone, which is follicle stimulating hormone, when a woman is on day 2 or day 3 or even day 4 of her period. At that time of the month is when the pituitary gland, which is a little gland that sits at the base of your brain, is making pulses, the FSH and LH hormones, to recruit the ovaries to grow the eggs. When the ovaries still have enough eggs that it's not difficult to grow an egg, then we don't need to make very much FSH to make the eggs grow. If, however, the ovaries are getting rather low on eggs, then the pituitary will need to make more and more FSH to push those ovaries to get them to grow the egg. So the FSH hormone on the period can help tell us how the egg supply is. When we measure the FSH on the period, we usually measure alongside it the estrogen hormone called estradiol, because it's also been found that if estradiol is elevated on the period, that is a symptom also of low egg reserve. As we get lower numbers of follicles, we make less of other hormones that suppress the estrogen level, so we see the higher estrogen production then. Then the third test we usually do to check on how egg supply is doing is to do a pelvic sonogram and look at the ovaries and count how many follicles we see in the ovaries. So they call that an antral follicle count. So if we look at the ovaries and count how many we see on each, if we see ovaries that have a lot of follicles visible, we know these are ovaries that usually will have a good egg supply, will be pretty responsive to ovulation medications. And if we see very few follicles, that warns us that these ovaries will probably be less responsive to the ovulation medicines. On these tests, one other important thing that can sometimes affect results is while a woman is on hormonal contraception, it does tend to affect both the AMH in particular, but it also suppresses the FSH on the period if she's taking the pill at the time it's drawn, and we'll see lower numbers of follicles. There's something about things like birth control pills or the contraceptive implants that the way they suppress the activity of the ovaries seems to affect these measures. So a woman who has a lower measurement of her egg supply while on them might want to consider stopping them if she's able to use something else for protection, and remeasure the hormones when she's been off it a couple months and see better where her egg supply is. Now, a very important thing about measuring egg supply is also to understand that it is looking at the numbers of eggs in the ovaries. It is not the same as predicting fertility. In other words, a woman who has a somewhat low egg supply may still be able to get pregnant perfectly fine at that time. She just may not have as long a window as someone else to get pregnant. If she has a low egg supply, her menopause is going to tend to be sooner, and so she may need to think about what her plans are for having a family if she's intending to have children. The one thing sometimes women will also ask is if there's anything in particular they can do to slow down the loss of eggs in their ovaries. Unfortunately, things like birth control pills and contraceptive, other hormonal contraception, even though we don't ovulate the eggs those months, we do still use up eggs. There are still eggs that grow to a lesser degree and are broken down and reabsorbed by the body. So we can't save our eggs just by taking a birth control pill. We can, however, avoid things that are toxic to our ovaries to minimize excessive loss of eggs. Smoking in particular seems to be damaging to the egg supply. It's been found that women who smoke on average have menopause earlier than women who do not smoke. So staying healthy in general seems to be good for our ovaries, in particular avoiding smoking. Now, typical signs of low egg reserve, if a woman's body's starting to get low on eggs, many times, first of all, when that body's first starting to get low on eggs, there will be no symptoms. But as the egg supply gets lower, we'll start to see that the periods start to get a little closer together. So maybe the woman who used to have a 28, 30-day cycle now is seeing her periods come 24, 25 days apart. So if there's a change like that, that often can happen when the egg reserve is low. It seems like when the egg reserve is low with that greater amount of FSH hormone we're making to make the eggs grow, that it tends to make whatever egg is going to dominate and ovulate go ahead and ovulate sooner, so therefore the next period comes sooner. So that's one of the first signs if a woman's going to start to develop actual symptoms of it. Then eventually, as the egg supply gets lower and lower, then the body starts to have trouble getting an egg to grow each month. So then we start to see more irregularity of the periods, either sometimes going 6 weeks between periods or skipping a period or two, and eventually getting hot flashes, and finally the periods stopping. In terms of causes of low egg reserve, the most common simply is aging. But if a woman also has had a surgery on her ovaries to perhaps remove a cyst, a dermoid cyst, or an endometrioma, that does some trauma to the ovaries and tends to lower the egg supply. If a woman's had a cancer and undergone chemo or radiation, that can also affect how her egg supply is doing. There seem to be, in addition, some genetic factors. Some women, it's common in their family that their mother and maybe their aunt or their grandmother had menopause on the earlier side, and that woman is at greater risk of having her menopause sooner too. She is likely to have been born with fewer eggs. There are a couple of very specific conditions that aren't so common, but we certainly see them, that can also cause early loss of egg supply. There's a particular condition called Fragile X syndrome, where there's a change on one of the X chromosomes the woman has that causes her to lose her egg supply sooner. And it can also be associated with higher risks of certain health problems in her children too, so that's an important one to diagnose if the woman has it. And then, not very common, there's another condition called galactosemia. That's a genetic defect that affects an enzyme in our bodies, but that also seems to affect the egg supply. Finally, another cause of loss of egg reserve can be autoimmune conditions. If a woman has an immune system that's being overactive and that she's making antibodies that might be attacking various hormone-producing glands in her body, for example, the thyroid, then it's possible that she's also producing some antibodies against her ovaries. If a woman has low egg reserve and has multiple signs of immune system issues, then it may be that her immune system is what's causing the measurements of egg reserve to look quite low. And in which case, there's a chance that if the immune system starts working better some point down the line, that the ovaries may start to behave more normally. So that's one of the few cases that that early loss of eggs may be reversible. But other than that, we have not figured out the magic bullet, how to just somehow make the ovaries sprout new eggs. There's a lot of research going on trying to figure out what we could do to try to preserve eggs better, but no one's figured out how to do that yet. So what do we usually do if a woman has a low egg supply? So obviously it depends on what the woman's goals are. If a woman is diagnosed with low egg supply and she's not trying to have a family yet, but would like to be able to have her own genetic children in the future, then we may consider trying to freeze her eggs. If we've caught what's going on early enough, then we may still be able to give her ovulation medications and get a whole group of eggs to grow in the ovaries that we can then use. We can freeze and have her be able to use in the future to have a family. Or she could decide, if she's low on eggs, that she might decide to use, if she doesn't have a partner, donor sperm to get pregnant. Or if she has a partner, then she may decide to move up her plans for having a family sooner if she knows that her egg supply is running low. If a woman has a low egg supply and she has been trying to get pregnant and is having difficulty, then our options usually become things like either ovulation medication, since a woman's body does naturally recruit a group of eggs to grow each month, but typically only stimulates one of them to keep growing to ovulate, and the other eggs that got recruited die. What we can do is give that woman ovulation medication and keep additional eggs growing. That way, maybe one egg is not the good one, but maybe one of the other ones is the good one. So ovulation medication can often be used. And then the other option also is depending on how many children she wants. So, if she wants to be able to have additional embryos banked for the future, then she could decide to do in vitro fertilization. We can stimulate her ovaries with some of the stronger ovulation medications we have, try to get a whole group of eggs to grow, get the eggs out, fertilize them with the sperm, make them into embryos, and that way try to have some embryos frozen also for future pregnancy, and perhaps have an embryo that we could use now. So that tends to be the most proactive option that we have if there's low egg reserve, as long as the ovaries still have enough get up and go that they can respond to the ovulation medication. If a woman's ovaries are very low on eggs, we may run into difficulties with the ovulation medicines, even using the strongest ones, getting the eggs to grow. If we're having trouble getting enough eggs to grow for in vitro, there are some ancillary things we give as part of the IVF cycle to try to coax as many eggs as possible from the ovaries. We don't give the same protocol of stimulation for in vitro to a woman with good egg reserve versus somebody who has a poorer egg reserve. For example, we may, instead of using birth control pills to lead into the IVF cycle to synchronize the follicles better, we may either shorten the course of the birth control pills so we don't oversuppress the ovaries, or we may decide not to go with birth control pills at all. We may give just estrogen starting after ovulation during the preparatory cycle for the in vitro. Many times we'll use higher doses of the ovulation stimulating medicines in addition. There's been some work looking also at additional medications like growth hormone, that some studies have shown growth hormone may help the woman's ovaries respond a little more strongly to the ovulation medication. Certain vitamins have also been studied that seem to have some benefits, considering an antioxidant such as coenzyme Q10 or other antioxidants may also help a little bit the quality of the eggs that we get. In addition, there's been some work done with melatonin. Most of these medications don't make huge differences in the numbers of eggs we get, but every extra egg counts. It might be the egg that is the one that produces the baby for us. And finally, if a woman has gotten very low on her egg supply and we just can't get anything else to work, there are still options to have a baby using a donated egg. Nowadays, since we can freeze eggs, egg donation has become a much easier process, although we can still use fresh eggs from donors. So it's possible donors to be screened. The donors are checked for genetic diseases, for infectious diseases, family medical histories gathered. So they go through a very thorough screening to make sure they're healthy, and then their ovaries are stimulated and the eggs are retrieved and are either used fresh or frozen. So even a woman who has run completely out of eggs and is perhaps completely in menopause can still take some estrogen and progesterone hormone to get her uterus ready for the pregnancy, but can then still carry a pregnancy herself and have a baby. So Anyway, I hope this has been helpful. Just a little bit about egg reserve and low egg reserve today, and I hope you have a great day.